Today's seminar is about re-engaging global surgery partnerships after COVID. Who am I? My name is Laurie Ellett. I'm a GYN oncologist who decided to leave my position at McMaster in Hamilton Health Sciences in September of 2020. And my goal is to spend 5 years that's remaining in my career in low resource countries like Cameroon. What I've accomplished to date is I did a diploma in tropical medicine at the London School of Hygiene in the late 2020. I was at Mabingo Hospital in Northwest Cameroon for the first 4 months of the year. I was recruited back to Newfoundland because of some staffing issues for the summer, and I head back to Mabingo on November 19th of this year through till the middle of next year. What I'm hoping to accomplish in this next 20 minutes or so is to give a definition to global surgery, discuss why we need partnerships and what happened during COVID and where we're at now. And the bottom graph kind of shows you those same objectives and the timelines that are involved. The definition of global surgery on the right-hand side is academic scholarly training and care provision relationships between high income and low middle income countries. Grant has described it in these 4 circles where clinical care is the big component of our activity, but global surgery also involves the education and exchange of trainees, importance of research monitoring and evaluation, and the importance of engaging in collaborations and partnerships. Pre-COVID, we know that surgical diseases accounted for 1/3 of the burden of diseases, and that globally 9 out of 10 people lacked access to basic surgical care. They were unable to afford it, the care wasn't safe, and the care wasn't timely. Why was this so? Well, it was impractical for many patients to travel to medical services, and there was also a shortage in healthcare personnel or physical resources. It's estimated that there's over 1 million numbers shortage in specialty surgeons, anesthesiologists, and obstetricians. Not only is there a lack of access, but access is linked to quality, and quality means that there's poor or inadequate training of the people that are currently in the workforce. There may be no assessment in training, and there's no quality control after training is completed. In fact, during my time at Mbingo in Cameroon, we had a surgeon trained from Togo come, and he had never actually seen or done a hysterectomy in his OBGYN training. He was in a government hospital, and the hysterectomy cases were moved to private hospitals where the physician could get a higher dollar value. And so the trainees had never done any kind of ovarian surgery or hysterectomies. And yet he was now a bona fide obstetrician gynecologist. So pre-COVID, we know that 75% of the world's population had access to less than 25% of the surgical procedures. And part of this, like I mentioned, was a paucity of surgeons. You can see the relationship of the number of surgeons in Canada to the CAR. The UN tried to meet this problem by implementing in their Sustainable Development Goals number 3.8, which suggests that there should be universal health coverage for all. The point of surgery should not be to deplete everybody's resources. The Lancet Commission on Global Surgery developed a framework, and we're going to talk about that a little bit later with recommendations, indications, and targets to try and improve access to surgery. But a big part of this is partnerships and the importance of comprehensive care and sustainable care and how partnerships can get us to that point. So during COVID, we found that in the high-income countries, when there were needs for personnel in ICUs or emergency rooms, surgeries stopped to divert those resources in personnel as well as in PPE to the places where it was immediately needed. We had stay-at-home orders, which led to social isolation and restriction of mobility. And this limited travel for a lot of the high-income staff who were in partnerships with low-income settings. And it not only decreased their ability to be present in person, but it also decreased the presence of the resources that were brought with them. So in essence, clinical care and delivery still happened in low resource settings, but a lot of the other factors were suddenly stopped. What happened post-COVID in the low-income countries? Well, before COVID, they still had to pay for healthcare, and post-COVID, patients still have to pay for healthcare. Pre-COVID, the social determinants of health were as they were, and now post-COVID, it's no different. In fact, it may actually be worse. And in areas where there were conflict, there still is conflict. This is the hospital that I work at in Mbingo, and you can see that the ability to social isolate or social distance is not present. In this hospital, patient families have to bring food, so you can't restrict families from access to the patients. Access to testing, either rapid testing or PCR, is really limited, so patients are admitted and go to the OR without those kind of testing options available. Even though we may be in a better scenario in high-income countries where more of our population is vaccinated, that opportunity is not existent at the moment in many low-resource settings. What COVID showed us is not only in high-income countries, but also in low-income countries, that there are very deep cracks in the health system, and it's really important to try and build sustainable systems, not only in our high-income setting, but also in the low-income situation. What have we found during COVID? Well, having fewer resources in low-income settings did not stop development, but it actually stimulated innovation for novel ways of trying to develop PPE or ventilators. But it really showed that instead of high-income countries coming with their solutions to what they think are the problems in low-resource settings, it's really the low-income and low-middle-income settings that have to frame their problems and identify solutions and bring partners alongside. Those partners may have systems already in place that can help, or they may be part of creating systems together with the low middle income settings. So in the Lancet Commission on Global Surgery, there were 6 domains that still need to be worked through. COVID didn't change these domains. They still exist and they still need to be uptaken and navigated. And I'm going to touch on a couple of them in the next few minutes. So whatever solutions are identified, they really need to be sustainable. In terms of workforce, the development of surgeons, one of the outstanding successes in 2008 was the Royal College of Surgeons collaborating with CASEXA in Africa to rewrite the surgical curriculum, develop objective standards for examination, and develop standards for membership and post-membership e-learning platforms. Not only do you have to train surgeons, but you need to train the services that work along with surgeons to do the job, like anesthesia and nursing. And there's a lovely example from Rwanda where the Human Resources for Health programming worked on a project plan to develop anesthesia and nurses. And they did this alongside 22 US academic institutions. Not only are they working in surgery, but they have moved on to include orthopedics, OBGYN, and neurosurgery. And it's really stepped up the quality of nursing care, not only generally on the ward, but with specialization in perioperative care. Task shifting is another opportunity for partnerships. So you may not be able to have an anesthesiologist, but you could have a non-physician anesthetic provider or a non-physician clinician help either on the surgery side or on the anesthesia side. And there is a lovely partnership for Surge Africa, which is trying to develop this mentorship program to strengthen teamwork, promote task sharing, and improve overall surgical capacity in the hospitals. The difficulty with programs is there needs to be some sort of not just standardized training, but standardized licensing and post-licensing evaluation and update. And that's a big gap that will need to require a lot of effort going forward. In terms of education, it's really important that the education is African or low resource country centered. It's great to want to bring laparoscopic skills in, but in Africa, the issue is a huge number of operations that need to be done quickly, safely, with few complications. And laparoscopy requires a lot of equipment, a lot of training, and may not meet the needs of the population at the time. So there needs to be a lot of planning about how that process gets implemented. Information management has been a big aha in high-income countries during COVID, but it is also a resource that has been developed in the low middle income countries. It can involve patient-provider visits, but that's usually by telephone as opposed to by Zoom. One of the things that we had great luck with in Cameroon, Kenya, Belarus was the fact we had linkage with the echo tumor boards. So we were able to continue to do case reviews on cancer cases or with colposcopy cases on a monthly basis during the whole pandemic. Telepathology and teleradiology is also in our setting. So if a physician was not available, we could download the assessments of pathology to the American pathologists or to other radiologists to help with patient care. I'm going to comment a little bit about education. It does overcome some barriers of educational travel, but it has its limitations as well. I have done some work in Guyana, and I was asked to give rounds in Guyana, and I found it really difficult to do that by Zoom. My presentation was on the big screen in the country, but I couldn't interact with the audience, and I couldn't get a feel for where they were at, whether they were understanding the concepts I was trying to relay, and I found it very difficult. So yes, they got my lecture on germ cell tumors of the ovary, but I'm not sure how much they learned or understood of it because of that lack of feedback. This is in contrast to the training I took in London for the diploma in tropical medicine, where each of us by computer was linked with our class and our educators so that we were always able to ask questions. There was a good interaction of feedback. So that was a learning situation. So that is one issue with the Zoom platform. But another issue is the huge cost of broadband in low resource settings, and a homegrown, a low resource solution to this could be that the telemedicine is given free or very low cost opportunity, or that there would be government sponsored network technologies to run these kind of educational or healthcare platforms. But at the moment, it is a resource intense issue in many countries. Surgical simulation is an opportunity for learning if that's already in place before COVID. I know of one center in Africa that did have surgical simulation models, but this may be a way to work forward for high-income centers that have that technology to bring it into low resource centers now post-COVID. But it is a way of trainees getting to learn tasks and putting in chest tubes, suturing, pig gut, whatever that is, to help skill development. I was one of the physicians that traveled a fair bit during COVID, but I will tell you that travel has very much changed. You always have to know the status of the country you're going to, in terms of how many vaccines do you need, what documentation you need, what COVID testing you need. This all costs money. Different countries, it costs different amounts. If the COVID test happens to come back positive, you need to have plans for isolating in whichever country you're at. You have to be prepared to wear a mask, not only in the airport, but also throughout your flight. And when you go to some low resource countries, social distancing is nothing that they understand. It's activity as usual. And I'll give you an example of this. We had a surgeon from the US who was double vaccinated with Pfizer. And that person was supposed to go back to the US a couple of days before I was supposed to go back to Canada. And she had a COVID test thinking it would be negative, and it was positive. And a day or two later, she has another COVID test and it's still positive. And it wasn't until a few days later that we both went for a COVID test that luckily I was negative and she was negative, so we could head back on our respective flights to North America. So the vaccine does prevent severe disease, but it doesn't mean that you won't be pollinated with virus from the activity that you've been doing in the country that you are a guest. In terms of governance, which is another of the Lancet objectives, there is a move to try and develop national surgical, obstetrical, and anesthetic plans that preceded COVID. Only 6 countries globally have completed these. Some of the other countries are formulating them, and some have expressed interest. Being in the cancer world, I very much appreciate the impact that plans have in getting national ministries of health or national educational bodies on board to move forward an agenda. So in terms of partnership, being at the table to help facilitate the development of these plans would be a really outstanding place for partnerships between high and low middle income country collaboration. And I just have to mention that last week, the Minister of Health from Guyana was here in Hamilton, and he has signed a memorandum of understanding with McMaster University to, again, develop the partnership for ongoing relationships in education, clinical care, and training of the different areas related to surgery and anesthesia and OB. And it is an outstanding example of what can move forward when we're kind of on the other side of COVID, and they're probably still in the middle of COVID, but as we move into our no existence with COVID as a fact and not a crisis. So I do have some references, and I'm sure these slides will be available for you to access after the talk. But I'd like to thank you for your attention, and hopefully I've given you some thoughts about where partnerships can occur on an individual, on a discipline, and on a systems basis. Thank you very much.